I taught this last EAP, got some feedback, cut some stuff down. It's actually, this PowerPoint was like 120 slides. It's not even close to that, don't worry, it's on like 34 slides now. We'll be in and out of here quick. Who does not have something to write with or on? Or both? All right, good. I'm gonna have some points here that I'm gonna tell you guys to write some stuff down. Highlighted some things that I've seen on tests in the past. All right, I'm not here to teach you chapter 21. I'm just gonna give you some stuff that I've seen and keep it moving. I think H1 now, you back up next, sir.
Emma, I think I am.
All right, here we go. All right, so general first aid rules, right? We got maintain breathing, stop the bleeding, prevent and or treat shock, okay? I don't necessarily need you to write that down, that's in the book though. All right, I haven't actually seen them ask the question saying that, but that's there. Know it. All right, so triage, what's that mean, everybody? Sword. Seeing that, you all are taking the E5 exam. I expect to see questions like this on your exam. All right, so know that it means to short in tactical and non-tactical environments. Excellent. All right, so first thing we're going to go over with triage is our non-tactical priorities. Okay, so non-tactical, we talk about priorities. Tactical, we talk about categories. All right, we'll talk about kind of the difference here later. All right, so we talk about priority one. You'll see this on your triage card in your non-tactical environment is red. All right, and these are your critical but require minimal time. All right, so this is something I want you to write down. Priority one, immediate. All right, write that down in whatever way is easiest for you in your cliff notes. All right, just remember that. All right, and then we have our priority two, which is our delayed. Those are annotated in the color yellow. All right, these don't require immediate care to save the life or limb. Anyone still need time taking down those quick notes? Okay, no worries.
Pay attention to those examples, because for triage, they will most likely all the time throw a scenario on there and have you label what category that's going to be, or priority in this sense.
Yes, pay attention to that, and pay attention to the setting. If in that scenario they talk about whether you're in a combat or in a civilian entity, right? Because that'll let you know whether you're in a different priority or category. All right, moving on. Here we go. Priority three is our minor. These are our what we call walking wounded if we were talking about tactical, right? Or these are our ones with our minor injuries. Okay. And then our priority 4 and 5, these are your black, which is your expected and or already dead, right? So we talk about expected, we talk about brain matter, pulseless and dead, right? Things of that nature. Okay. Anyone still taking notes on those? Okay, no worries. Take your time.
Do we have this too?
Yeah.
I have the slideshow. I'm going to send it to y'all.
I like you to write stuff down because I think if you write and hear, it helps you remember. And just in case you are, I want to say, take note of the highlights. Don't write every single thing on the slide. Okay.
So if you see exposed brain matter or something about something dealing with the head or brain on the test, it's not going to be your immediate. It's going to always fall into this expectant category.
Right. In tactical or non-tactical settings. Good over there? All right, moving on. Here we go. So now we're going to jump into our tactical triage, right? Note that we're talking about categories now as opposed to priority. So that's another telltale sign in the test if they start talking about priority this versus category that. All right, no, we're not talking about one or the other. Okay, we're talking about this. All right, so in tactical, right, our category one is our minor or walking wounded, right? Which is a stark difference from our non-tactical, right? Because we're talking about getting our fighters back to the fight, right? So they are our category one, walking wounded. All right, and then we jump into our immediate. These entities require life-saving emergency surgery, right? They've been shot, they're bleeding out. We got to get them fixed up right away. Moving on. Boom. Category 3, these are our delayed. All right, So they need surgery, but it permits delay, right? So examples, they've been shot in the leg, we got it controlled with a tourniquet, we got some time to get them on the bird and get them out of there, all right? Well, yeah, that's right, right around there. Bleeding under control with tourniquet. There you go. Category 3.
And that is the exact scenario they will throw on the test to throw you off. As long if it's an external hemorrhage and they are stable, then they're going to be falling in that delayed category.
Is this different than what we're teaching in TCC? Like this is a different category of emergency medicine?
Well, this is, so I will say that there are some subtle differences from tactical triage in your Corpsman manual versus TCCC instructions, but it's subtle. So, why? What's the difference that you're seeing here?
Well, because we teach in just people that when we're struck at the hospital that tourniquets and massive hemorrhage regardless go in your critical. Because you have to have, if you're in like AOR, they have to be reevaluated because you can't take the tourniquet off.
So TCCC is more about us immediate life-saving care on the scene, right? So yes, we're tourniquets, controlling the bleed around the spot, right? This is talking about triage on how we want these our patients to get the warfighter back on the field. Huh?
They're already adding into it.
So for tactical triage, so that's like if we're in a fight, right? I want to get more bodies back there. So in triage scenario, I'm still trying to get everybody back on the ground and back into the fight. Now, you as a corpsman providing immediate care to the individuals that are injured, you're then going to make sure you're following the PMARCH-P algorithm, stopping the bleed, and going through that sequence. That's kind of the difference here is medical care for triage or for TCCC, and then triaging those casualties with this chapter.
And like I said, you'll see some subtle differences like that between the Corpsman manual and just another, right? Your Corpsman manual's got a lot of chapters that go over certain things, and then you got your specifics and your bibs on other entities of it, right? Unfortunately, you got to know it all, right? So understand a little different. You'll see some other stuff in here like that too, all right? So again, priority 4 in tactical is our expected, all right? So if you ever get hung up on priority category, non-tactical tactical, right? Like I said, we see brain matter, we see somebody is dead, right? They're gonna fall into that last category.
Pay attention to the BSA for burns too with that percentage, because that'll be on there when they'll say how much surface area is burned, and that's going to let you know it's going to be expectant.
30%. It's a good one. Take note of that, yeah.
Is that the only one of tactical that's going to be a priority instead of category?
Maybe it was just labeled wrong.
Yeah, mislabeled. That's what I mean. Category. Good catch. Appreciate you. Categories. Tactical. Got that down? Moving on. All right, so TCCC. All right, this is our triage algorithm for TCCC. All right, we're not gonna go diving crazy into it, but care under fire, what are we doing?
Under fire, security, fire superiority.
Fire superiority, getting them off the X, all that good stuff, right? Man, we get down, this is when we're gonna start performing our cursory evaluation. It's got a red light, laser on?
Yeah.
So it's middle button.
No, top button.
Oh, shit. There we go, right? Get into our cursory evaluation. This is where we're going to make a determination about whether they are walking, wounded, or expected. If we need to proceed with further care, this is when we'll make that determination about whether they're an immediate or a delayed. All right, so that's kind of how that works with TCCC without going crazy into it. Airway management. All right, a few things I saw in airway management that I've seen over the years in there, especially going in for an E5 exam. All right, so some things to take note of right here. All right, 15, 10, and 5 seconds, all right? This is the time we spend suctioning out a patient, that's a wait. Along with never suction, only suction what you can see, what you can see. Why is that? Why do I only suction what you can see?
You are pushing things further down.
Pushing things further down, what else? Okay, there we go, right? We're already in a bad situation. We don't want to make it worse by making somebody throw up or furthering some damage in there. I like this 15, 10, 5 because for adult, child, and infant because it's nice and easy sequence to remember.
Put a big star next to that because that has been on the test multiple times with the seconds.
There we go. Next up, we jump into our OPA. How do we measure an OPA? There we go. Corner of the mouth to the ear. Excellent. Seen that before? Know it? Let's see, how do we measure an NPA? No, better yet, what does NPA stand for? Devil dog back there.
Nasopharyngeal airway.
Excellent. How do we measure that? Nose to earlobe, over here? All right. Over here. There it is, just like that. Measure from the nose to the earlobe. What do we lubricate with?
Did you just say spit?
Or, lubricant if you got it on hand.
Do not lubricate with blood.
Yeah, right. We don't want to necessarily use blood because blood coagulates. It could be hard, make it rigid and hard to slide in. All right, so water-based lubricant, if you got that on hand, if you're gonna pinch, use your saliva. All right. Most of these are built for the right nostril. Are we gonna force it down to the nostril? No, right? What are we gonna do if it's hard to get in? Don't use it, try the other nostril, right? Let's try the other one, get it in there. Good. Take note of that. How to measure it. All right, airway manager, copy tube. Anybody ever use this thing?
I've seen them in, we've seen them in ICU.
Okay. Anybody else? I've never used one, but it's in there. I went and got one the other day just so I could look at it a little more. So it's another option for a supraglottic airway. All right, so it is pretty nifty. I've never seen it used in real life, like I said, but it is something that you can kind of put in, not blind, but you can get it in there. All right, it's got 2 tubes on it. All right, so that you can try one. You're blowing up air in the gut. Put it in the other one, and you're gonna get it in the airway. I like that. Nice and dummy proof. All right, so we'll get in there to save the patient. All right. Questions on that? Combi tube. I have not seen this on the exam before,
No, never.
but I don't know much about it, so I thought I would put it in there.
Isn't this the one where they tell you can break their teeth?
That's just your regular, or not the OPA, I'm sorry, the epiglottis, that's just.
You guys do break the teeth.
We break the teeth,
Oh, the anesthesia does. Oh.
Yeah, just your regular,
like ET tube.
yeah.
Yeah.
You can break them.
Gotcha. All right, so there it is. Haven't seen it on the test though. Keep that in mind. All right, moving on. Cricothyroidotomy. All right, what are our landmarks? Somebody give me one. Cricoid membrane. What's the other one?
Thyroid membrane.
So your thyroid, cartilage, and your cricothyroid.
Thank you. What did you say back there?
Cricoid cartilage.
There you go. You said membrane, but it's all right. All right. And then what are we cutting? Thank you. Membrane. You said it right. All right. So what else we got? How long is our vertical incision? What is it? 1 inch vertical incision. Excellent. You got it on that. All right. Adam's apple. Obviously not as prominent in our females. All right, but so if you haven't felt this and you're getting ready to go operation or something, make sure you guys feel on people know what that stuff feels like. 1.5 inch vertical incision. Right there over that membrane. Use your little hook. Separate. Insert your ET tube.
Again, Corman manual is a little more outdated. We know it's 1 inch now for that incision, but because of when it was written way back when, it was 1.5 at the time.
Yep, that's
Are we
great, man.
learning 1.5 or are we learning?
So I'll tell
You don't. You guys do not have a TCCC instruction on your
In the bib.
bibs, I don't think, unless there's the.
You've taught HPC, somebody taught it yesterday.
I'll look and see if that 1 inch is on there. But if that one's on there, you're going to go by the newest instruction, which would be the 1 inch.
Okay.
And then again, all these airway adjuncts are going to be based off of mechanism of injury, right? So if somebody has a burned throat or soot in their throat, are we going to be trying to do a NPA or OPA? Where are we going to jump to? Right.
All right, let's talk about a little bit of chest injuries. All right, we did some of the things we're looking for. Right, difficulty breathing without signs of airway obstruction, suction chest wound, most serious. Failure on one side of the chest rise, enlarged neck vein. What's an enlarged neck vein? Is that a late or early sign? Don't look at that. Huh? Late sign, right? A deviation. Excellent. All right. So what should we have done already?
No, you're, yeah.
Tension pneumothorax. We shouldn't have gave him that already. But what should we have done to treat that? Needle D. All right. So talk about needle D. What's our landmarks?
Your second intercostal space, midclavicular, your fifth intercostal space, and your
13th intercostal space in your nose.
There we go.
Stop.
All right. So between the second, third rib, right? Mid-clavicular is what I heard. Excellent. What kind of, what are we using? Not from you, T-Triple-C expert. What are we using over there, Devil Dog? Devil Dog, excuse me.
The needle beam,
Yeah.
It's the gauge.
18 gauge.
18 gauge, let's try. What else we got there?
They keep changing it.
No.
14.
10 gauge, it's a little big. What else we got?
14.
14 gauge, excellent. What about the length of our needle itself? Oh, okay.
Who would you say?
It's
What'd you
3.5
say?
feet.
3 point.
It is 3 1/4.
Full out of katana. All right, no. All good guess. I got you. So 3.25 inch, 14 gauge needle is what we're using, right? Mid-clavicular in the second intercostal space. Are we going on top or below or on the bottom of a rib? Top of a rib. Why is that? Not you? Who else? Nerves, blood vessels. Excellent. We talked about, so I looked in this through the chapter in chapter 21 to see if they talked about the secondary site. They don't talk about it in chapter 21, but we all know it's there, right? So what's our secondary site? All right, go tell us.
We're talking about the mid-axillary.
Mhm.
You know, it's the fifth of the intercostal space, mid-axillary. But we're not teaching that.
Oh, it's not even being taught anymore.
They also don't teach. They don't have the nipple line on here too, which is important
They
too.
don't.
Because if you go over, what are you going to possibly puncture? So you have to go to the, I don't know what the terminology is, but to the left-hand side or outward side of the nipple.
You will go distal of the nipple.
There you go.
We're only doing we're only using this one now, and it's double bond for each time.
Okay, good stuff. I gotta get back over to T-Trips.
It's gonna change, like.
Oh, it should change
2 months.
because
Oh, yeah.
it's always
Yeah, they just came out
easier
with a
to
new,
get it right
instruction.
here.
A new policy of how they do it. It's not, they do it by tiers or something like that now.
Yep, tier 1, 2.
Everybody will be tier 3.
All right, sounds good, sounds good. Well, this ain't changed yet. 3.25, 14 gauge, mid-clavicular, second intercostal space. Definitely know that. Seen that 100,000 times on every kind of different test. Moving on. All right, oxygen. I'm not an RT tech. I'm not about to go crazy into it, but these are some things that I do remember seeing. All right, so with our oxygen mask, all right, it's our simple mask we put over the patient's face. All right, 10 to 15 liters per minute and 90% oxygenation. All right, I will take note of that.
Yes. Test question.
I would also take note of the nasal cannula is 1 to 4 liters per minute and 24 to 44% oxygenation. Why is there such a drop off with the nasal cannula?
Because it's supplemental.
What's that back there?
They'll just be shoving her up their nose.
Yeah, right. It's not they're not filling the whole face up with a mask and sealing it tight. Everyone got those numbers? Anyone not have those numbers? All right, moving on. All right, shock. So shock is inadequate tissue perfusion. There's 3 major types. We got our hypovolemic, which means loss of blood volume. Distributed, which is vasodilation, and cardiogenic, which is the problem with the heart pumping the blood to the body. All right. We can talk a little more about distributive, some different types of distributive. How I found this is to know these big 3 and understand that vasodilation means that the vessels are getting bigger and they're not able to perfuse the blood to the body as they should. Right? Compensated, decompensated, and irreversible are the stages of shock. All right, just like we talked about earlier, like that 15, 10, 5, same kind of concept here, right? Compensated, it's not progressive, right? So our body's essentially able to, it's dealing with it. It's a good chance of recovery, we're making through. Decompensated means the BP is failing, blood volumes drop, we're not doing as hot, and then our irreversible stage is our terminal stage. Treatment normally doesn't result in recovery. All right, so just understand those 3 stages, right? As they go, you're dropping, you're getting worse as you go.
For the
Terminology is pretty self-explanatory for you. Decompensated, compensated.
For the shock, they love to talk about percentage of loss of blood volume. So make sure you're putting a star next to that 15 to 25% for decompensated.
Anyone need a second on this slide? All right, we are moving on. Brain to go 4 to 6 minutes without oxygen before permanent brain damage occurs. This is not how much blood is in your body. I just thought this picture would be a nice little shock and awe for you. There we go. All right, so death from massive hemorrhage can occur within 2 minutes. All right, the chapter 21 says 2 to 4 minutes, I believe what it says in there. All right, but within 2 minutes, I have seen that before. How fast the body can go. 6 minutes oxygen, then 2 minutes
We said you've
What?
seen somebody die from massive hemorrhage, or you've seen that on the test?
on the test. Question. I have seen somebody die in Iraq yet from accident, but another day. All right, patient assessment. All right, ABCLU, what's that stand for?
Alert, verbal, and
Painful, unresponsive.
And unresponsive, excellent. So when we're talking about our initial assessment, all right, you have 30 seconds-ish to do your general impression. We talk about their cheek complaint, if they can give it to you. Airway, are some ways that we open our airway.
Trauma, job thrust.
What was
Why
that?
am I
Say it
missing
out.
these slides?
Yo, whoa, hold up. He said what?
One more time.
Trauma, job thrust.
Trauma draw.
Well, he said- he
I
said-
heard that one. What's
He said
school me on that?
That's when you basically push up on the jaw from the back and, push up with the arms.
there's just a.
Oh, okay, job thrust. All right, okay. I thought it was something different from them. Like I've been in the schoolhouse for a minute teaching surgery. I was like, I don't know, maybe things have changed out there. Like trauma, it's like, ugh, get open that mouth. All right, cool. And then what's our other way? Head tilt, chin lift. Excellent. All right, so our breathing. How do we assess that, especially on the battlefield? Our breathing. That's our little
Look,
thing we
listen,
got.
feel.
Look, listen, feel. Okay, good. Remember that stuff. Going basic. All right, and we're looking at our circulation, right? Our color, tip, radial pulses for adults, children, radial or cap refill, and infants. We're looking at brachial pulse and capillary refill. If we have a radial pulse, what's our systolic pressure? 90? All right. Good. All right, control major bleeding, trip shock, and load and go or stay in place is what we need to be thinking about in our initial assessment real quick. All right. Moving on. All right, DCAT BTLS, let's go back. What's that stand for? You give me D, right here, page 3.
Deformity.
What is it? All right, everyone, come back.
Deformities.
Put me on the spot.
Deformities. Deformities.
Deformities, all right, give me the next one.
Contusion.
Contusions, what we got next? Abrasions, what's next? Right there.
Penetration.
All right there. Thought I was gonna say that, no.
I'm so sorry. I don't really know what we're doing.
Oh, okay. All right, we're going down the DCAT BTLS algorithm. No worries, how about you right here, Devin Dot?
Where we at now?
C.
DCAT B. Bruises. I'm gonna give you the rest. All right, there we go. Burns.
Burns.
Tenderness, lacerations, swelling. All right, we do this from our head to our foot. I would know this. I would write this down, or at least write down DCAT BTLS and go back later and write in what they mean. All right, seeing that on the test.
So the ones that everybody mixes up, because I just heard you say it. B is always gonna be burns, because a contusion is what? A bruise, right? So your bruises are always gonna fall under contusions, and your B is always left for burns.
Excellent. All right, and then we have our sample, all right, which is our signs and symptoms, allergies, medication, past pertinent medical history, last oral intake, and events. All right, and then we can break down our signs and symptoms even further. All right, so definitely write down sample if you're not familiar with it, or if it's something that you need to brush up on, and then come back and write in what they mean next to it.
I hope y'all are killing it at HMSB over here.
Yeah.
We don't have here.
You get away with that?
Actually, in 4 years, we never did.
Oh, it's coming in probably.
Nah.
Someone's gonna tag
Who said that?
it. Oswald, yeah.
Yeah, it's Oswald.
Yeah.
No worries. No worries.
All right, moving on. Here we go. All right, so for our signs and system, all right, so we can use our acronym OPQRST, which stands for our onset, provocation, quality, radiation, meaning does it spread anywhere, severity, and time. All right, another one. All right, for me, I'm a surge tech. This stuff was always hard for me because I didn't do sick call and stuff like that, and I didn't go operational for a while I was in. I just did surgery, so all of these things like that and the stuff H1 Nally was talking about, like man, I had to read a lot because all I knew how to do was like pass instruments for a long time. All right,
I know the pain.
so make sure you guys write this down, OPQRST, and take note of that.
What does the picture at the top say?
It says more than just letters of the alphabet. OPQRST.
Help! I've fallen. I can't get up.
It was a contact.
Moving on.
So you just
All right, grade injury indications. All right, so we got some variations in pupil size, failure for pupils to constrict properly, progressive loss of strength, and CSF fluid leakage from the ears. What's our test we utilize for CSF? Halo. Here you go, Beyonce. Don't give them anything by mouth, right? They can't think right. They might not.
Again, I
swallow
mentioned
right.
anything affecting the nervous system is always going to make your pupils either unequal or constricted.
Boom. What's PERLA stand for?
Light accommodation.
Good. Know that. All right, broken bones. All right, so unless necessary, do not attempt to straighten it. Why is that?
You can see the artery.
Not just breaking more bones. So say you have a fractured femur
Yeah, you can-
and you move a fractured femur, what could you possibly do? You can nick the femoral artery and make your patient bleed out.
Not her dead.
From the inside.
There you go. All right. So why would we attempt it?
Because you don't have,
They're all
you
like,
have an absence
There's circulation, the absence of what was that?
of distal pulses.
Absence of distant pulses, right? And we might want to give it a go depending on where we're at, right? If we're in theater, if they say, hey, we can't get nobody there for a long time, all right, we might have to try to get tricky out here and see what we can do. All right, have that tourniquet handy if their leg is still around and all that. All right. Again, yeah, don't try to do it unless you gentle traction, gentle. All right, pelvic fractures.
Yep.
You can hold a lot of blood in here, y'all. We gotta be careful. So we want to try not to move our patient unless absolutely necessary. So
What?
again, depends on your environment, right? If we're stateside, maybe we can just relax and wait for the EMTs. If we're out there in the field, in wherever, exactly. we
Why,
gotta go.
why do they highlight pelvic fracture though? What is the pelvis attached to? Your spine. So if you move a pelvic fracture, what are you possibly going to do to that spine? Yes,
C-spine
sever it, and then they're
stabilization
going
is no
to
longer
paralyze your patient. So that's why a pelvic fracture and C-spine is one of the main things to pay attention to when treating an emergency situation.
Yeah,
Yes.
absolutely.
We don't teach that anymore.
I teach it all the time in DCCC.
Nope.
Have been teaching it for years.
We don't teach.
All right.
Chapter 21 says this. That's all I can tell you. All right, and also keep in mind that your pelvis will hold a tremendous amount of blood, so that fracture may be
Saying they
holding
don't
something
teach
in
pelvic
place.
fractures and
Right, so I don't know if
They don't
they
care
still,
about-
devil docs over here, do y'all carry a pelvic binder when y'all go out and do stuff? Y'all like, I'm never sorry, I want to do that, no, I'm kidding.
That's why I said-
Yeah, so I mean, if you got a pelvic binder on you to keep that stuff in place, you may be jarring loose and allowing more blood flow to happen too, so keep all that in mind when you're treating your patient. All right, penetrating eye. I messed this up last time, all right, but I got it right this time. All right, so do we cover both eyes?
No.
Yes and no.
I say yes.
You say yes, why?
Because you don't want the other eye to move, because then they follow each other. So like, this is a donut, but you don't want to put pressure on them too. So you want to down.
Okay, so she said yes, because you don't want both moving if you got something penetrating and doing more damage. You're saying no, why?
Because if you cover both eyes with a patient that's a walkie-talkie with only one penetrating eye wound, then you have a litter patient, and now you've gotten rid of a litter that you need for a critical patient.
All right, so here, that's exactly the right term, situational, right? So one side is more of a non-tactical, one side is tactical, right? If we're outside and someone gets a freaking whatever stuck in their eye, we can probably cover both eyes and tell them to stay calm, all right? If we are in Russia, because they're getting crazy over there and we're fighting, right, we might not want to cover both eyes because it's cold out there and we need to keep it moving.
And I gotta give you a gun and start shooting you.
Boom,
You
right?
can shoot one.
You can shoot one.
Exactly.
Supposed to. You got a strong arm.
So keep that in mind. It is noted in chapter 21 to bandage both eyes unless in a tactical situation, then just the affected eye. All right. Boom. The Lund and Browder chart for accurate assessment of the percent of body surface area. We knew it as the rule of nines. All right, it ain't as easy, I don't think, anymore as it used to be back in the day. That's a lot of 2 3/4 and 3 1/4 and craziness like that. So I don't know how simple this is. I haven't had to deal with an actual live burn patient and use one of these guys and fill it out. I mean, I guess I take the time, pull out my calculator or some shit, get it all done, because I'm not too smart like that to be doing 2 3/4 and 3 1 in my head on paper. All right, but back in the day, it used to be like just like 4 1/2 and this was 18, it was real easy. The actual true rule of 9, they ain't like that no more. Needless to say, if you're out there, make sure you got a copy of this or something so you can accurately assess the burn of your patient. Yeah, that's it with that. All right, heat exhaustion, heat strokes. All right, I had a whole bunch of other information about this. We're gonna break it down real simple. All right, what do we do for heat exhaustion? Also heat cramps, and I'm just hot. All right, what are some things we do? Oh, so what's that? I heard. Right here. Rehydrate. Okay, get some fluids in them. What else? Get them out of that hot environment. Find some shade. Cool. What else? Holding off of them if it's tactically smart to do so. Yep. What else? Electrolytes. Fluid. Yep. Okay. Cool. Absolutely. If you're in an environment where you can get ice, if you're in Iraq, you're probably not going to be able to get ice there in a good time frame before it melts. But yeah, cool them down. Absolutely. All right. Good. And some things to note, like they might be moist, clammy skin, pupil dilated, normal or subnormal temperature, as opposed to heat stroke, right? Where we're gonna have dry, hot skin and pupils constricted, very hot, high body temperature. All right, this person needs immediate medical care. Remember that. I've seen that on the test. You need immediate medical care if you are going through heat stroke symptoms. 104. All right, you're still going to try to do these other things for this person who's going through heat stroke, but they need immediate medical care. All right, anaphylactic shots. Shock, excuse me. All right, so signs and symptoms, know them. But here's the big thing I want you to know. All right, treatment is 0.3 to 0.5 milligrams of epinephrine auto-injector, IM or excuse me, sub-Q. I said IQ.
Make sure you read it so you don't stab yourself in the
Yeah. Anybody ever using an EpiPen? Yeah, a couple people. Moving on. All right, analgesics on the battlefield. All right, a lot of numbers here. Write them down though. These things have been seen before, for sure. All right, so if they're still able to fight, we can give them Mobit, 15 milligrams. We have Tylenol, 650 milligrams, both by mouth. That's what PO stands for.
I thought that's bro officer. Oh, he's on his way.
If they are unable to fight, we have our oral transmucosal fentanyl citrate, 800 micrograms.
Fentanyl lollipops.
Everyone's done T-CCC. You should know that they take this bad boy to their finger, let them suck on it until they pass out, falls out their mouth, all safe.
The lollipop, right?
Yep.
The lollipop, fentanyl lollipop. And we talk about our morphine sulfate, 5 milligrams, IV or IO, promethazine, 25 milligrams, and moxifloxacin. That's 400 milligrams. Be sure to take note of all those. Those are important.
Meloxicam, Tylenol, and moxifloxacin.
Mobic works so good, they only get you to do one a day. Anyone still taking notes? It's okay. Yep, there we go. All right, moving on. All right, so we talk about a little bit more of morphine. All right, the adult dose, 10 to 20 milligrams every 4 hours. Do we give morphine to somebody who is a respiratory depressant?
No.
Excuse me, respiratory distress, I should say. All right, no, because why?
They could die.
They might die. But why would they die?
Slows down their heart rate.
Exactly, right? Morphine's going to chill you out, like a lot, like slow your breathing down. If your breathing's already slowed down, it's not the option you want to go with, all right? Or any kind of chest injury, such as a sucking chest wound, all right? Definitely know those numbers.
Good afternoon. If you signed up for the Saturday, our new to the movies, please meet in Burke Therapy 301.
Go on, sorry.
Thank you.
Why don't you move the shit down? We good there? All right, here we go. Any questions? I know, right? See, you ended with a smile. Everyone's happy. Good. All right, y'all. Well, that's all I got for you. If there's no other questions, if anyone ever needs any